So before we move on to the next panel discussion, I want to mention that despite our best efforts, we weren't able to secure a Republican lawmaker to join us today. And understandably, we know that there's a lot going on with the budget reconciliation process. For example, the Budget Committee met at 1 a.m. last night. So busy time on Capitol Hill. So on that note, I want to direct your attention to the screen for some recent highlights from discussions from Republicans about the topic at hand. Let's take a listen.
It ought to be just a basic foundational principle. It is wrong to cut health care for the working poor. And that's what we're talking about here with Medicaid. My state is a Medicaid expansion state. Over 20% of Missourians, including hundreds of thousands of children, are on Medicaid. And they're not on Medicaid because they want to be. They're on Medicaid because they cannot afford health insurance in the private market. These are working people and their children who need health care. And it's just wrong to go and cut their health care when they're trying to make ends meet, trying to help their kids, trying to make sure that they're able to provide for their families. So I hope that the House GOP and the Senate GOP will get the message here. By the way, President Trump has said the same thing: no Medicaid benefit cuts.
We have got to change the direction of this town. And to my colleagues on the other side of the aisle, yes, that means touching Medicaid. It went from $400 billion in 2019 to $600 billion this year. It'll be over $1 trillion in the 2030s. We are making promises that we cannot keep. We do need to reform it. We need to stop giving 7 times as much money to the able-bodied over the vulnerable. Why are we sticking it to the vulnerable population, the disabled and the sick, to give money to single able-bodied male adults? We shouldn't do that. We should reform it. But guess what? That message needs to be delivered to my colleagues on this side of the aisle too. We are writing checks we cannot cash, and our children are going to pay the price. So I am a no on this bill unless serious reforms are made today, tomorrow, Sunday. We're having conversations as we speak, but something needs to change, or you're not going to get my support. I yield back.
We have a tremendously unified party. I don't think we've ever had a party like this. There are some people that want a couple of things that maybe I don't like or that they're not going to get. But I think we're going to have tremendous, not luck, we have tremendous talent. This man has done an incredible job as Speaker. We are looking at one thing. We're not doing any cutting of anything meaningful. The only thing we're cutting is waste, fraud, and abuse. With Medicaid, waste, fraud, and abuse. There's tremendous waste, fraud, and abuse. There's incompetent things put in. We have illegal aliens that are multiple killers with multiple murder records getting Medicaid. I don't think anybody minds if we cut that. The Democrats, on the other hand, are going to destroy it because they're going to leave these people on. We're cutting 3 things: waste, fraud, and abuse. We're not changing Medicaid, and we're not changing Medicare, and we're not changing Social Security. And if I wanted to do those things, I would have done it during my 4 years that we were.
It is now time for our panel on aging, access, and affordability. Please welcome Julia back to the stage. She's joined by Edwin Walker, former Deputy Assistant Secretary for Aging at the Department of Health and Human Services, Sue Koob, CEO of the Preventive Cardiovascular Nurses Association, Peter Rubin, Executive Director of No Patient Left Behind, and Natalie Kean, Director of Federal Health Advocacy at Justice and Aging. Welcome all.
Thank you, everyone. Edwin, Sue, Peter, Natalie, thank you so much for joining us. We have a pretty big panel, so maybe I'm going to start with a broader question. And I know a lot has happened in the past 5 months or so. So I want to go around and hear how or if your work has changed since the new administration. Edwin, you seem to be very animated. Let's start with you.
Well, I would say yes, my work has changed because I thought I had retired, which I call being rewired, to do things on my list like travel and read books and go to museums and take advantage of Washington, D.C. And yet, what do I find I'm doing? Trying to console staff, trying to figure out what the chaos is all about, trying to figure out what is still here that we've always enjoyed and known and has provided care and support to millions of senior citizens across the country. And we're trying to put it back together. We're trying to save, we're trying to preserve, we're trying to protect. So that's what I've been doing.
Sue?
Thank you.
Yeah.
I would say that in general, our policy and advocacy priorities have not changed, but there's so much happening around policies shifting around our priorities that we really are just trying to stay on top of things and really try to stay as informed as possible so that we're ready to speak up when needed. So just a little bit more of a scramble in terms of trying to stay on top of all this changing policies.
Scramble, yeah. For reporters, we're kind of in the same boat, so I can relate. Peter, how about you?
Similar response, where our guiding principles have not changed. I mean, we do seek to achieve affordability and innovation for patients, payers, and society. I think it's just how you get there is a little different, and I think the ability for us as our sort of expert network of investors, the small biopharmers they fund, and the patient advocates, providing that sort of expertise to provide real-time line of sight and insights to the folks we're disrupting is something that we've been able to do as well.
And Natalie.
So Justice and Aging, our mission is to fight senior poverty, and we're still doing that. The programs that we're talking about today, Medicaid, SNAP, Medicare, Older Americans Act programs, these are absolutely indispensable tools to fight senior poverty. They need to be strengthened. That's what we were working on a lot last year, and now we're in the mode of protecting these programs, making sure we're preserving them so that we can strengthen them.
So Natalie, I want to zero in on that because when we look at Medicaid and SNAP in particular, and as Allison brought up, Medicare also is being impacted. Those programs are facing very potential cuts, at least in this House bill. And as Congresswoman Chu said, once we go into the Senate, maybe some things change. So what does that process of preserving look like when you have a majority of Republicans and President Trump kind of pushing in this direction?
Yeah, I mean, this is the biggest threat to Medicaid that we've seen, the biggest amount of funding that has ever been proposed to be cut from Medicaid. So hundreds of billions of dollars. There is no reinvestment. This is not strengthening the program. This is really cutting it. And there's a number that I hope everyone can keep in mind, and it's 1 in 5. So there are 1 in 5 people with Medicare who also rely on Medicaid. They cannot get access to health care or meet their basic needs without both programs. 1 in 5 older adults ages 50 to 64 are also enrolled in Medicaid. So they need Medicaid for their primary health insurance before they become eligible for Medicare. Many of these folks have had to retire early. They have chronic conditions and disabilities. They absolutely have no other option besides Medicaid for their health insurance. And then 1 in 5 people enrolled in SNAP are also older adults. So this is, these programs are incredibly important for older adults. And we're just really worried about the combination of cuts and what would happen. So there are direct cuts being proposed in the legislation to both Medicare and Medicaid. One of those cuts is rolling back rules that really modernized how older adults and people with disabilities can enroll in Medicaid. There are programs that Medicaid helps people pay for Medicare costs. Medicare is actually quite expensive, especially for low-income seniors. There's a $185 a month Part B premium, as well as 20% cost sharing. Medicaid helps cover those costs. So when you take that away, and Allison mentioned the 1.3 to 1.4 million people with Medicare who could lose this assistance, when you take that away, the consequences are so horrific. It means people won't be able to see the doctor because they can't afford that copay. It means that $185 a month Part B premium starts getting deducted from their Social Security check every month. And that's the only income most of these folks have. So what do we see then? We see eviction notices because they can't pay their rent. The consequences are very serious, and these programs are already under-enrolled. And so when we see cuts to the SHIP programs that help people navigate, we know that fewer people who are eligible for this assistance are going to be able to get it.
So Sue, on the question of the patient, how is the cardiovascular health of older adults being impacted by disruptions in primary care access or even staffing shortages in some?
Yeah, I mean, we're seeing a huge impact on preventive services, right? So if we see a shortage in our workforce, there's less opportunities for preventive care, for regular checkups and visits and screenings for things like blood pressure and cholesterol. And so the long-term outcome, it was sort of mentioned by another panelist, it's so ironic that we're seeing these massive cuts in terms of saving money when it's really going to cost the system that much more money, because in the end, we're losing access to these preventive services, which are so important for cardiovascular care and other chronic diseases.
Right. Edwin, I'm curious because you obviously have, experience in this area. We're seeing, lost my place there. What advice do you have for younger policymakers, advocates who are taking up this work right now? I mean, we're sort of, and I don't mean to use a cliche, but we're sort of in unprecedented territory. We haven't seen cuts like this for quite some time.
My advice for young folks is to understand that it's not just a seniors issue. Mm-hmm. It's an everyone issue. In fact, what we're seeing and what we clearly know will be the case is that with this level of cuts, it's going to shift the burden of cost and the burden on families down to states and families and community-based organizations, including faith-based organizations. What that means for a younger generation is that they're going to be taking care of older individuals. It's going to completely change their lives, and it's going to impact their ability to go to work because they're going to be the caregivers. They're going to need to be the caregivers. I want to also comment on the preventive component because, as Allison mentioned, all of the preventive services under the Administration for Community Living were also eliminated. That means that it's not a wise approach. It is going to result in higher costs. We administered an entire suite of healthy aging, evidence-based prevention initiatives that focused on, they were tested by NIH and other research organizations to prove that it would increase the ability of older people to continue to live in their own homes, to continue to be healthy, and not have a burden on Medicare, Medicaid. And we know that, like falls, something like as simple as falls, $80 billion in costs, 75% of which is borne by Medicare, Medicaid, is a result of older people falling, because the rate is 1 in 4 older people fall every year. If we don't have the funding to invest in falls management and teaching people how not to fall and to ensure that their homes are safe from falling, we're only going to increase the burden, the cost burden, and it's also the leading cause of injury, both non-fatal and fatal injuries in older adults.
Peter, I want to bring the conversation to prescription drugs, your realm, because we know that there's been, some bipartisan progress and there is bipartisanship on that issue, but we know that No Patient Left Behind has pushed for systematic drug pricing reform. How do pricing dynamics uniquely impact older Americans under Medicare?
So a few things. First of all, I think I would sort of combine our mission as how do you enact insurance reform so that if a doctor prescribes a treatment and the insurer authorizes it, it's affordable to the patient. And that's really a function of the lower out-of-pocket cap that the IRA put forward that only applies to Part D as in drugs and not the Part B as in biologics. So when you start seeing things like the pill penalty, which incentivizes new R&D in shots that are covered by Part B as in boy that are not covered by the out-of-pocket cap, that's something that's concerning. when the reality is, as I think you heard earlier, that by incentivizing new small molecule R&D, you not only get sort of, it's just as risky to develop and discover as a large molecule, but it's less costly to manufacture, something you can take at home, it's interchangeable at the pharmacy, and so it goes generic almost immediately. So that's the type of innovation that you want to continue, and the other concerning part about the pill penalty is that it actually reduces the incentive for generics to try and enter the market, and so that means fewer generic drugs, and fewer utility of existing new drugs. So that's the sort of dynamic that we're trying to show, that how you get these long-term savings by ensuring that balance of affordability and innovation.
Right. And just to drill in on that point,
please.
we know that the EPIC Act, which the administration has endorsed, addresses the pill penalty, but I guess what does the reform look like for older Americans in the long run?
Well, one, I think the reform for older Americans is one to sort of get back on track and sort of first of all, like as Edwin was saying, we call ourselves No Patient Left Behind because patients, it's all of us. We're all going to be one day patients, and we're all hopefully going to be seniors as well. So if you think about it rather than just sort of like a year or electoral issue, but as a multi-year sort of what does the nation look like in 10, 20, 30 years, that's the perspective I think that all of us bring to the debate. And so when it comes to seniors now and in the future, it's how do you ensure that pipeline of innovation continues? How do you extend the out-of-pocket costs to the near retirees in the ACA coverage, and also how do you ensure that there are insurance reforms to ensure that actually patients see saving at the pharmacy counter, such as the PBM reforms. And I think you can take that holistic approach where you're able to extract the same amount of revenues that you would under current law, but do it in a way that actually preserves affordability and innovation and extends benefits.
Right, and Sue, I want to get your perspective on PCNA's emphasis on patient education. How do we empower seniors to manage their health when a lot of these support programs are being cut?
Yeah, I think it's going to be a huge priority that if we see cuts to these programs, that we're able to inform seniors about what's coming in terms of their care. And so last year we partnered with MapRx, and when there were changes to Part D, we really wanted to make sure our nurses were informed about these changes, because our specific nurses treat over 2 million patients per year. So there's a real opportunity to use the nursing community as a way to educate our seniors in terms of changes that are coming, and how maybe we can think more about using community services, or also encouraging our seniors to meet with legislative representatives, talk with reporters about some of the negative things that these changes and how they're negatively being impacted.
So I want to go down the row again. We've heard the concerns and sort of, throughout this morning, and kind of the warning signs, the unfortunately negative impacts we're seeing. What can everyday Americans do? And you touched on this, Sue, but what can they do if they're concerned about losing these programs and if they depend on these programs? I'll start with you, Edwin, yeah.
Well, I'm going to speak specifically about what we refer to as the National Aging Services Network, funded primarily through the Older Americans Act, which I would mention will, just in the month of July, along with Medicare and Medicaid, celebrate 60 years of success. Those three programs were part of President Johnson's three-part strategy to combat the war on poverty. At that time, most older people lived in poverty without access to physicians or hospitals or health care. That has completely changed in this country as a result of the success of these programs. It would be a shame to see these cuts across the board be implemented at a time when we're about to celebrate the success of these programs, and that have changed the trajectory of older people's lives in this country, enabling them to live in their own homes and communities and to maintain their health. We've been a leader in the world in this regard, and it's just a shame. So I believe that what older people can do and family members can do is make it known that this is going to truly impact their lives. It's going to change their lives dramatically. Everyone needs to be involved. It's not just, as I said before, it's not just the seniors. It's going to impact every aspect. We have 54 million caregivers, family caregivers, for whom, if we didn't provide support and services, it's estimated to exceed $600 billion a year. Well, what are we going to do? So people have to write. People have to be involved. They have to be engaged at every level. They have to talk to individuals about what the impact really will be on them.
Sue.
I agree. And I think as a representative, as a CEO for a national organization, we need to look at trying to bring together patient organizations, professional organizations, and other agencies to really raise these patient voices and tell the stories about what we're seeing in terms of how detrimental these cuts are or will be. And I think it's really all of us to come together as a community to try to raise those voices.
And Peter, from your perspective?
So I think there's a few things, which is one, silence is not a strategy. There's a whole cohort of people who think if I just sit in a corner and be quiet, nobody will find me, no one will pay attention to me. That's not the case. Secondly, I also think that just outrage about preserving this past status quo is not a sustainable strategy as well. Not just because, disruption is clearly in the mindset. And I'm old enough to remember when the extremism of the Contract with America transformed into the Balanced Budget Act of '97, which ended up not only preserving the safety net, but also eliminating the deficit and actually almost eliminating the debt. So from my perspective, it's what are the productive, proactive solutions that we can all bring together that that leverage the disruptive innovation into that sustainable future.
Natalie.
Yeah, telling stories is the most important thing. Medicaid is part of all of our lives, especially from the perspective of older adults. If you've had a loved one in a nursing facility or receiving help at home with activities of daily living, chances are Medicaid was paying for that. And Medicaid also probably provides health insurance for the caregiver, direct care worker, and often family caregivers as well, who are supporting older adults in the community. So, it's so important for all of us to find that connection with Medicaid and know if it's not part of our lives today, it will be one day, and we want to make sure that it's there for all of us.
Edwin, I'm sorry, Sue, were you going to say something? No, no worries. Edwin, we talked about what everyday Americans could do, but I wanted to get your perspective on what should advocates and state leaders now do to safeguard these the aging services infrastructure, because you hear Republicans say, well, we're punting SNAP, punting Medicaid back to the states. That's their argument.
I've been around a long time, and I worked at a state level. States cannot absorb this. Family members cannot absorb these cuts. Community-based organizations, faith-based organizations cannot absorb these cuts. It's simply not true. And it's compounded by the fact it fails to recognize the sheer demographic imperative we have here. In less than 10 years, we will have more older people than we have children in this country. How in the world can anyone believe a good strategy is to reduce services at a time when we're about to have an increase in demand? Mm-hmm. So people need to speak up. They need to be very vocal. They need to understand that it impacts them at a very personal level. I'll say this, my history throughout my career, it was always that we're the best kept secret. Well, we shouldn't have been a secret. We should have been known at the local level. People never even understood that it was a federal program. They embraced the Older Americans Act because it went from the federal level down to the state, down to through area agencies to local community providers. And they felt a real sense of ownership. It was theirs. On the transportation van, it was their name. On the Meals on Wheels, it was their program. That's why it's been successful, because states put in their resources, local entities put in their resources, and older people themselves contributed their time and their resources, their money, because they felt it was theirs and because they knew that if they did that, it would expand the services to provide those services to people, other people in need. And that's been the beauty of this program. We don't need to cut it. The timing is all off.
So it's sort of an effort between local communities, the state, and the federal government.
It's always been a partnership, a huge partnership. In fact, GAO studied the Older Americans Act structure, this national aging services network that we talk about. And they said it's really the right model for federal programs. It has a small federal footprint that provides guidance and sets goals. It then goes down to the state and local communities. The strength has always been at the bottom, at the local level. That's what's also been studied by other countries. It's bottoms-up planning. It is responsive to the needs in local communities, and it has worked so incredibly well. And now we're facing, based on the leaked budget, elimination of many of the protections in the programs. Allison mentioned the long-term care ombudsman program, a program where you train and certify volunteers to go into nursing facilities and other long-term care facilities to speak on behalf of residents who don't have a voice, who can't protect their own interest. Why in the world would you get rid of that? It makes no sense. Not to continue funding for the Adult Protective Services program that addresses issues of elder abuse, neglect, and exploitation, where there's the data shows that at least 1 in 10 people are exploited every year. What's going to it just makes no sense at all.
Right. Natalie, Justice in Aging has sounded the alarm on racial disparities in aging. Where do you see those inequities deepening, and what can we do to address them?
Yeah, thanks for this question, because older adults experience a lot of harm based on historical discrimination that compounds over the lifetime and that continues. And in fact, if we look at the connection between Medicaid and housing, we see some of those disparities, and something in this reconciliation bill that will actually make that worse. So to qualify for Medicaid long-term care, people have to spend down their income and assets. The one thing that they're allowed to keep is their home that they're living in. And we know that home ownership is one of the few ways to build intergenerational wealth. We also know that there has been a lot of discrimination. So people of color have had a harder time building that wealth. Well, under the reconciliation bill that's being considered right now, they want to cap the value of the home that can be disregarded when someone is becoming eligible for Medicaid. And when we see rising housing costs, someone who's lived in their home for decades has almost no income, no other assets. They could be shut out of Medicaid or forced to give up their home. And that only worsens disparities for the next generation.
I know we have a few minutes left, but I want to ask a question, and hopefully on a lighter note, a question I ask Allison. Is there anything in this field that you are hopeful about? Is there anything any kind of silver lining right now? I know it's a dark time, but I just want to get your perspective, Edwin.
I am an eternal optimist, and I have dedicated my life to this field, a field I fell into. I didn't plan to come into the field of aging, but I often say I fell into the field and then I fell in love with it. What I believe, the hope I have, is that the people who have dedicated their lives to the issues that we are all talking about today will continue to dedicate their lives, will continue to raise their voices, will get others who are not aware to understand and to appreciate the issues that really matter to families and older people in this country.
Yeah, it's been mentioned by other panelists today, but I think what's really sort of incredible about this whole thing is how many people have really come together to talk about these issues and think about how we can combat and try to maintain funding for these services. And so I guess I would say the silver lining is really just to see the community really step forward on this.
Right. Peter.
I think from, my approach is that you sort of see the extremism on both sides of sort of the differentiation is the political value. And I'm hopeful that this debate, which, is informed by, I think, a lot of perspectives, leads to sort of the sort of sensible center, common sense path forward, in the sense of like, yes, it's silly to think that anybody would fake cancer to get free chemotherapy. So what's the point of increasing out-of-pocket costs when your doctor-prescribed treatment is authorized by the health plan, and you see health plans restructuring their benefit structure so that they actually raise, out-of-pocket costs for people in that situation. So I think, the ability for people to say, hey, we're gonna have this big fight, but then as the process moves forward, we can move towards the center. Let's find the good ideas on both sides and actually achieve that sort of affordability and innovation that I think we're all hoping for.
Natalie.
Yeah, what gives me hope is that Medicaid is incredibly popular, as is Medicare, and polling shows again and again that the people are with us on wanting to protect this program, all of these programs from cuts. And so, as others have said, the bringing the community together behind this, I think we are here to protect it, and we'll do everything we can to rebuild and strengthen it in the future.
Well, on a hopeful note, thank you so much to all of our panelists. We appreciate your time. What a great discussion. Thank you all for joining us.
That brings us to the end of our program. Thanks to all of our great speakers this morning. On behalf of the Hill and our sponsor, Alliance for Aging Research, we'd like to thank everyone who joined us here in person and who joined us online. If you missed any portion of today's discussion, the full event video is available on thehill.com. Thank you very much and have a great day.